Ma'am, we are live now.
Respected doctors, my name is Dr. Aishwarya, and I welcome you all to the Extra Mile TV. It gives me immense pleasure to welcome a very renowned speaker, Dr. B.D. Goswami. Sir has completed PhD in gastroenterology from Russia, fellowship in GI and liver disease from University of Virginia, USA. Ex-HOD of Gastroenterology, Guwahati Medical College, and Sir is presently at Dispur Hospital, Guwahati. The topic for today's webinar is Persistent Ring of Fire. What's new in the management of GERD? I now request Sir to take over a session. Thank you, sir.
Thank you, Dr. Oseja. At the beginning, I must thank the Zydus team for giving me this opportunity to come here and present my discussion on the gastrointestinal reflux disease. My friends, today for next few minutes, we are going to discuss about this issue of gastroesophageal reflux disease. Gastroesophageal reflux disease, basically, it is a big problem. All the time we have to see these patients, and before the start of reflux disease, probably it is pertinent to know what is the problem. So before the disease, it is the gastroesophageal reflux that matters. It means the effortless movement of the gastric content from the stomach to the esophagus. That is where the problem, because ultimately this effortless reflux from the stomach to the esophagus, it gives the chance to damage the mucosa of the esophagus and ultimately makes the patient troublesome all the time. And that is what we call gastroesophageal reflux disease. Then again, by definition, what is it called? The latest definition by Montreal, the gathering and consensus, this is what the actual and final gastroesophageal reflux disease definition. It develops when the reflux of the stomach contents to the esophagus causes troublesome movement, symptoms, or the complication. That is what we call gastroesophageal reflux disease. This is the problem here, what we see. So, for example, when the content of the stomach with the acid, with the pepsin, with the bile comes to the lower part of the esophagus, it can damage the mucosa like this one, even the ulcer formation, and the patient becomes symptomatic. That is what we call gastroesophageal reflux disease. Then again, today, this is the most common problem which is encountered by any physicians or any gastroenterologist all over the world, because it is a worldwide problem. Then there is another terminology is coming up that is called non-erosive reflux disease. The content which is coming from the stomach to the esophagus, yes, what I have mentioned already, it can damage the mucosa of the esophagus, but sometimes the mucosa may be completely normal. That is what we can see on endoscopy. And still the patient may have the symptom. That is what, by definition, the burning retrosternal discomfort for at least 3 months, but with the normal esophageal mucosa on endoscopy. Then we call them the non-erosive reflux disease. This is a part of actually reflux disease. In fact, if we see the last century, the beginning of the last century, we had more and more gastric carcinoma and the peptic ulcer. But towards the end of the last century, we got to know that there is more and more esophagitis or non-erosive reflux disease. So that's why, in short, you can say that the gastroesophageal reflux disease itself is a disease of the 21st century. So understanding GERD, it is almost a century because in 1906, the first time from Tillotson W. Boston from US, he first described the peptic ulcer of the esophagus. That is what now we have realized that it is the gastroesophageal reflux disease. That's why in 2006, the Montreal Consensus, they has clearly defined what I have already shown in my slide. That's what it is, the 100-year, ultimately the major evolution of the concept of gastroesophageal reflux disease, what we have today. It is not that someone is suffering from reflux disease alone, because we have got all over the world almost 7% of the individuals, they experience the heartburn almost daily. 14% they experience heartburn once in a week. Almost 21% they ultimately experience once in a month, and almost up to 78% or 9% pregnant women have got heartburn almost daily. And out of them, almost 48 to 80% have got the esophagitis, where there is the inflammatory changes or ulceration. And both male, female, we equally suffer from gastroesophageal reflux disease. What already I have mentioned about the different parts of the GERD, the phenotypic classification, what we call today. At one end, we have the non-erosive reflux disease or NERD. At the other end, we have got the erosive esophagitis when there is inflammatory changes in the mucosa. And finally, if it continues, it will end up with Barrett's esophagus, the mucosal changing. And finally, from here, it can go to gastroesophageal, mainly the adenocarcinoma of the G junction. So these three unique group of the patients are coming up in reflux disease. And this, what I have mentioned here, that the non-erosive reflux disease, NERD, they have got the peculiarity because ultimately most of the atypical manifestations are found in this group of patients. Whereas in the erosive esophagitis, mostly we get the chance of having the stricture or the bleeding and so on. Mostly it is a complicated one. That's why we have got the complication of gastroesophageal reflux disease. And finally, the Barrett's esophagus or esophagitis of this end, we have got the adenocarcinoma of the esophagus. That's why in different part of the three groups have got the different presentation. That's why we should be very much aware about it. So what is the pathophysiology, the possible mechanism of the gastroesophageal reflux disease? What we have got the lower esophageal sphincter here between the esophagus and the stomach. Normally, it is very much tight. It is compacted. So whenever the food comes from the esophagus, goes to the stomach, it is relaxed. And after that, it becomes very much tightened and closed one. But sometimes if there is a relaxation completely or lax lower esophageal sphincter, the stomach content with the food material even, without the food material, the acid or pepsin, which are very much essential for our digestive system, or even bile, it can go to the esophagus. And that time particularly again, as the cleaning system of the esophagus is normally, I've got the normal salivation, we have got the tissue resistance of the esophageal mucosa, and also the peristaltic movement usually acts against the damage of the mucosa of the esophagus. But here in the reflux disease, it is found that there is salivation is decreased, the resistance of the tissue of the mucosa is impaired, or there may be the impaired the peristaltic movement of the esophagus. That's how ultimately it leads to the changes inside the esophageal mucosa, leading to the inflammation. And again, sometimes suppose the pyloric mucosa, the spasm is there or gastroparesis is there. So the stomach content cannot go easily to the duodenum and the further to the jejunum. So in this case also, the stomach content can go back to the esophagus, and also it can lead to gastroesophageal reflux disease. And there are again some substances which ultimately lowers the lower esophageal sphincter pressure. The hormone, some food material, then is a natural agent, then some medication. So all these things ultimately makes the lower esophageal sphincter a bit relaxed, and it can contribute to the pathogenesis of gastroesophageal reflux disease. There are also some factors that is identified today for which is responsible for this problem of gastroesophageal reflux disease. What is it is your increased frequency of the reflux. Very frequently, if there is going on the reflux, more problem will be more and more one. If there is increased duration of the reflux, also the injurious effect of the refluxant. Together they act and probably make it worse in case of gastroesophageal reflux disease. Again, the severity of the GERD, it depends upon these four factors: the reflux rate, the digestive potency of the refluxant, the acid clearance, and tissue resistance of the esophagus. These four factors work together and they decide the severity of the reflux disease. That's why we call it a spectrum of the gastroesophageal reflux. What we have got already mentioned, NERD, non-erosive reflux disease. We have got the erosive reflux disease and also the complicated reflux. So these three different parts of the reflux disease has got the importance here. The complicated reflux, what we get even the nocturnal acid breakthrough, at night they may suffer from some problems. There will be extraesophageal syndrome, I will discuss later on. Also, we have got the different sort of the complication like stricture of the esophagus, Barrett's esophagus, or adenocarcinoma. This group of the complications comes from this particular group or part of gastroesophageal reflux disease. Then again, I should mention about the obesity. And today, as all over the world, we have got the more obese population. We should remember that the obesity is directly associated with the amount of the reflux. And also reflux occurs even the patient has got the normal or hypertensive lower esophageal sphincter or the normal esophageal peristalsis. So obesity itself makes a big difference in the pathogenesis of reflux disease. Also, the BMI or lower esophageal sphincter pressure, they are inversely proportional. Also, the transient lower esophageal relaxation is directly proportional with the BMI. There is high BMI, this transient lower esophageal sphincter relaxation is more and more, and that's why we have got the reflux disease. So this is one of my patients who had the obese. He was an obese person and recurrent. The heartburn was there. We did the endoscopy. We found that he has got the ulcerations in the almost tear of the esophageal mucosa in the lower end. This is what we have got the narrowband imaging, and clearly you can see the difference in white light and the narrowband imaging light. So what is the clinical features we have got? In case of gastroesophageal reflux disease, all of us we know the typical symptom what we have got: the heartburn, acid regurgitation, hypersalivation, non-obstructive dysphagia or odynophagia. But again, atypical symptoms also we can get it, like the chest pain, the respiratory symptoms, or sometimes with the hoarseness of the voice. These are different type of presentation we see. But nowadays, we have got more and more presentation with the extraesophageal symptoms. I will discuss a bit later on. But this is the pie diagram showing very clearly that maximum cases, majority of the cases, it is the regurgitation. Then we have got the odynophagia in dysphagia-like symptoms, or sometimes we have got the respiratory symptoms next to it. So once after another, we have got the different presentation in different type. Then again, we have got the complicated reflux disease. These are the complications with the stricture formation. And this is the complication, in fact, the ulceration, stricture of the esophagus, Barrett's esophagus, or adenocarcinoma of the lower part of the esophagus. So what happens? The symptom generation in esophageal disease or gastroesophageal reflux problem. In one end, we have got the reflux. In the middle, the reflux directly can cause the problem, and most of these group of patients, we can get the regurgitation on the chest pain. But if you come to the left side, there is a chemostimulation, which is acid mediated. Whenever the acid is coming to the esophagus, in this group of patients, we have got more and more heartburn. In the other end, again, we have got the mechanostimulation, which is volume mediated, more amount of the content of the stomach coming to the esophagus. This type of presentation we can get mostly in the form of the respiratory problem or chronic cough, asthma like symptoms. That's how actually we have got the different symptom generation in gastroesophageal reflux disease. We have got the mucosal damage already after the reflux. Also, there is widened intercellular space of the mucosa of the esophagus. And even after that, if there is esophageal the acid exposure for a long time, there will be the stimulation of the sensory nerve endings of the esophagus, and ultimately we can get more and more symptoms of the gastroesophageal reflux disease. Of course, we have got the modulating factors here. These modulating factors already I discussed about the duration of the reflux, the proximal extent of the reflux, the composition of the reflux head, the psychological factor, or some other factors we'll discuss one by one later on. Then again, there are some issues coming up nowadays, the cough, wheeze, sore throat, and many more, which earlier we did not thought about are related with gastroesophageal reflux disease. Let us see how it happens. These presentations, what we call the extra or supra-esophageal manifestations of the gastroesophageal reflux disease, like pulmonary problem in the form of asthma. Then we have got the chronic bronchitis, aspiration pneumonia, bronchiectasis, pulmonary fibrosis. We have got the ENT problem like throat clearing problem, cough, laryngitis, hoarseness, globus sensation, pharyngitis, or the problem of the vocal cord, granulomatous changes, or even laryngeal carcinoma. Also, some other form of presentation can come from these supraesophageal manifestations like non-cardiac chest pain, sleep apnea, or sometimes even dental erosions. All these are now related with gastroesophageal reflux disease. Sorry. A very important point here, those patients who have got this supraesophageal manifestation, usually they don't show the normal clinical presentation, which are usually presented like acid irritation and all. This is the very important point we should remember. Typical presentations are absent in this group of patients. Then again, if we see the relationship between GERD and the asthma, not all cases of asthma, but some cases of asthma are related with gastroesophageal reflux disease. Like whenever the patient has got the reflux disease, ultimately there will be small, short time aspiration, what we call the micro aspiration of the stomach content coming from the esophagus. It goes to the pharynx and larynx, and ultimately it causes the pulmonary syndrome. Then again, it can lead to hypersensitive lung. Then along with the other stimuli, it can lead to the asthma. And when a person will be having the asthmatic problem, there will be negative intrathoracic pressure, and also due to the use of different medication, they can ultimately lead to some more reflux. And it will be just a vicious cycle. Once asthma, next it is more and more acid reflux, and again it lead to back to your asthma. Then again, what we call normally gastroesophageal reflux disease, that's why we have got another terminology coming up, the laryngopharyngeal reflux disease. Because of their new things coming up nowadays related with the gastroesophageal reflux disease. Then again, there is sleep disturbance in patients with gastroesophageal reflux disease. What happens here? There are two basic mechanisms are described. There is nocturnal acid reflux in case of reflux disease. There will be micro aspiration, what already I have mentioned. And from here, it can lead to exudative mucosal reaction in the pulmonary tract. And ultimately, it can lead to the arousal at bedtime. So sleeping person will wake up immediately. And again, another mechanism is explained here. From the reflux, it will go to the esophagus. It will ultimately, through the vagus nerve, it can cause the bronchospasm. And ultimately, the patient will have the problem of the arousal or sleep apnea. All these problems will be coming up. So sleeping disturbance and the GERD are to some extent related, and that is established today. This is what, in short, I am showing here. If the person has got the sleep, so after that, there will be more and more reflux in some percentage of the population of the GERD people. So what we have got, if there is more reflux coming to the esophagus during sleep, there will be prolonged acid contact time during the sleep, and ultimately it will give rise to the sleep disturbance. Once there is sleep disturbance, it will ultimately, through different mechanism, it enhance or stimulate more and more reflux, and GERD population will be increasing. That's how also they are correlated. Then there is another question. Sometimes there is a point we should always screen this population of gastroesophageal reflux disease. Why we should go for it? Because we have got the persistent GERD, yes. After that, it will almost 50% cases end up with esophagitis, what I have already shown in the video clip. And 10 to 15%, they will end up with the Barrett's esophagus. And all these three groups ultimately end up with the adenocarcinoma. Not all, but this is what the prevalence we have got, 5 to 10%, and incidence is 0.5% of this GERD. Then again, next question will be, should we investigate these patients? And of course, yes. But the point is when to do the testing of the diagnostic or whatever you may call it. When to investigate? First of all, if the diagnosis of the gastroesophageal reflux disease is uncertain, if there is an atypical diagnosis, there is a symptom associated with the comorbid conditions, inadequate response to the treatment, or if there is a recurrent symptoms or any form of surgery for reflux disease, before that we have to go for investigation of this patient thoroughly to see what is inside. There are some alarm symptoms again where it needs to investigate this patient. Like if the patient has got the symptoms of the dysphagia or dynophagia, GI bleed, iron deficiency anemia for a long time, weight loss, vomiting, early satiety, all these symptoms warrant immediately we should go for the investigation of GERD population. For the diagnosis, these are different methods we have got for the analysis of this patient. 24-hour pH monitoring, a manometry of LES, manometry of the esophageal body, upper GI endoscopy, barium study, prolonged monitoring of the motility of the esophagus, then acid perfusion test, and sometimes even we should go for radionuclide studies. So all the cases, we may not need an endoscopy, but some cases definitely it needs because if there is a brief history of symptoms in elderly population, if it is associated with the weight loss, if there is dysphagia or bleeding or odynophagia of these GERD patients, if the patient is not responding for at least more than 3 months with H2 receptor antagonist, if there is extraesophageal symptoms, or on X-ray if we see some mass, stricture, or ulceration, then only we have to go for investigation. You can see from this video clip in the lower end of the esophagus of a patient of GERD symptoms. And also, I have already mentioned that the majority of these cases nowadays, we have got the narrow band imaging facility. We can compare the changes with the white light and changes of the mucosa of the lower end with the narrow band imaging. You can clearly distinguish what is the changes inside the esophageal mucosa. So here, on this basis, endoscopic classification we have got find out, and that is what we call the Los Angeles classification. The grade A means the one particular area only we have got the mucosal break. If it is more than that, here you can see in one side, this is another side, the grade B. Grade C will be more than that, and finally in grade D will be extensive damage of the mucosa of the lower esophagus. So now coming to the therapeutic objectives of the gastroesophageal reflux disease. Of course, we have to treat them because really it needs it, not only to symptom-free life, but also to prevent the complications of the reflux disease. And that's what we can do it through the increased pH, if we can do it. If we can increase the esophageal clearance, that also will be helpful one. If we reduce the gastric volume, we have to try to increase the emptying time of the stomach and to restore the lower esophageal sphincter tone. That will be really helpful for this patient because it can ultimately give the symptom relief of the patients. It can relieve or healing of the ulcerations or mucosal damage of the mucosa. And also we have got the preventing the relapse of the symptoms and preventing relapse of the complication. That's what our aim and objective of therapy of gastroesophageal reflux disease. We have got the medical options, we have got the endoscopic options, and also we have got the surgical options. The only point is what we want to choose. So coming to medical treatment, before medical treatment, probably it will be better to go for the lifestyle modification. Avoid large meals, avoid acidic foods, decrease the fat intake, avoid lying down just after the food or both daytime or at night time. Elevate the head in the bed of the head 4 or 8 inches will be a helpful one. Then again, you avoid medications that may actually potentiate the reflux symptoms. And also you avoid the clothing that may be very tight around the waist. And also you try to lose weight, but I have already showed in the slide, the obesity is a major factor. And of course, you have to stop smoking. So this is what the lying down position or supine position can diminish the protective barrier against the gastroesophageal reflux disease. If you see here, the salivation and swallowing system is decreased here in lying down position. Esophageal clearance is also decreased for the acid, and also the gravity mediated drainage is decreased in lying down position. So immediately after food, don't go to bed. Then again, we have got the different pharmacological management, starting from antacids, we have got the H2 receptor antagonists, we have got the PPIs, and also we have got the prokinetic agents of different brands. Then coming to the focus of the gastroesophageal reflux disease management, always we should remember it is a compensatory, not a curative one. It is all about the acid. It may be antacid use, H receptor antagonist, PPI, or the fundoplication. Ultimately, our whole aim is to reduce the acid secretion from the stomach. So antacid, we have got the benefits and also we have got the disadvantages of using it. I'm not going in details about it. But we have got the H2 receptor antagonist. What we have got here is the first effective medical treatment. Up to 38 to 72% symptom relief you can achieve with H2 receptor antagonist. Almost 50% healing rate if we use it in double the dose of normal H2 receptor antagonist. But we have got the PPI, and this is the drug of choice today in reflux disease. Almost 92% cases we can ultimately make them symptom-free life, and also 92% cases you can heal the mucosal damage or the ulcerations. And also we should just mention that no long-term complications are found till today with the PPIs. You can compare here in this slide with the H2 receptor antagonist, almost 3 months or 12 weeks, the freedom from the symptoms, 48%, and with PPI it is almost 77%. Similarly, 12-week healing rate of the ulcerations or the inflammatory changes, we have got the H2 receptor antagonist 52%, PPI is almost 84%. So we have got the advantage of the PPI used in case of gastroesophageal reflux disease treatment. This slide shows the placebo, H2 receptor antagonist, and the PPI, and everywhere it is showing clearly that we have got the advantage of using the PPI. In short, in this slide, I am showing clearly the lifestyle modifications or antacid, a response in case of gastroesophageal reflux disease, 20%, H2 receptor antagonist, 50%, single dose PPI, 80%, and increase the dose of the PPI, double the dose sometimes. Definitely, almost 100% cases we can get the symptom relief or the healing rate of the esophageal mucosa. I mentioned about the spectrum of the gastroesophageal reflux disease, where I mentioned about we have got the NERD, we have got the erosive reflux disease and complicated reflux disease. What treatment we should propose here? This is the group where we can use the on-demand PPI. So on-demand PPI is basically whenever the patient will be having the symptoms, you use the PPI for some time, for 1 week or 2 weeks. After that, once the relief of the symptoms, you can make them or taper the dose of the PPI. But if the patient has got the erosive reflux disease, probably for a long time you have to continue the PPI. But if it is a complicated one, it is a high dose of the PPI, double the dose of the PPI should be continued for this group of patients. Of course, PPI is the pillar of the GERD therapy. It may be omeprazole, esomeprazole, pantoprazole, lansoprazole, or rabeprazole, whatever it may be. A PPI is a PPI is a PPI. So all the PPIs are highly effective. There is no doubt about it. But there is hardly any substantive differences in the clinical relevance. We should be aware of this fact. Then another terminology also I should mention about the refractory GERD. So what is refractory GERD? Basically, if the patient does not respond or clinically he has got significant impairment of health-related well-being, despite the patient is in the PPI therapy. So by definition today, after the consensus, if it is the double the dose, that means twice daily dose of the PPI before breakfast and before the evening dinner for 4 to 8 weeks, then we call them a refractory GERD. You can see one of my patients, actually I'm showing here again, the damage of the mucosa, even if the patient was getting double the dose of the PPI. So why PPI fails? There are so many issues, but before that probably it is better to understand the target of the PPI. In case of gastroesophageal reflux disease, it is here. The PPI will work on the acid clearance, and also it can ultimately neutralize the acidity of the gastric juice. But it fails because if the patient has got other than that the problem, suppose abnormally number and composition and volume of the reflux, PPI don't have any role on that. It cannot control. Or the tissue sensitivity, the hypersensitive mucosal reaction of the refluxate, PPI cannot control it. That's why actually PPI fails, and that's why in this group of patients, what we call the refractory GERD. Then another point I should mention about the acid pocket. Basically, it is an unbuffered layer of the acid which is sitting in the cardia or the top of the milk. And if the patient has got this cardiac area with the acid, whenever there will be relaxation of the lower esophageal sphincter, immediately it goes to the esophagus and it causes the trouble of the reflux disease. Then again, the acid pocket and also hiatus hernia, if these two live together, then also there is more and more chance of having the esophageal damage, and it can cause a refractory GERD-like symptoms. So then, what is our treatment point of view in refractory GERD? Yes, we should use the PPI, double the dose first if it is not responding in the single dose. If it is still not responding, you go for extended release PPIs, the dexlansoprazole or modified release system nowadays available with the other PPIs. After that, if it is not responding, you switch over to another PPI. Suppose initially you are using a rabiprazole, now you change the brand to your esomeprazole or vice versa like that. And sometimes you can add some other medications, H2 receptor antagonists at bedtime. You can use the GABA agonists, you can use the antacid along with the PPIs, or different antacid can be helpful one. And sometimes also you can add a prokinetic agent. But you should remember that the prokinetic agent has got its own side effects, so be careful about using it. Then we have got the anti-reflux surgery. In those patients which failed in the medical management, we have to think of the surgery. The patient sometimes prefer for the surgery because for a long time continuously taking the medication, and most of the time they have got the symptom, they may prefer for surgery. If there is a complicated GERD, and if the medical complications attributable to a large hiatal hernia, in those patients probably they may go for surgery and we may need surgical procedures. But again, there is a treatment gap. We have to ultimately accept it. Almost 40% of the GERD patients, they fail to respond to the aggressive and suppressive acid medications. But almost less than 5% they undergo fundoplication, that means surgery. It leaves a high number of the patients receiving inadequate treatment for the GERD symptoms. This treatment gap in case of reflux disease clearly showing here 65 to 75%, yes, they will be happy with the PPI, either single dose or double dose. Anti-reflux surgery, if I put it 5%, but rest gap will be there where we need something else, which can ultimately give relief to the patients of gastroesophageal reflux disease. So what we can do here, we can go for the endoscopic approach of the GERD gap. These 40% cases, probably we have to treat with it. This is the first of all the endoscopic procedure. We started with the radio frequency ablation, what we call the stator therapy. It is found to be effective one, safe, well tolerated. What it is done here, mostly you can see from the pictures, it increases with the radio ablation or radio frequency. We can use it and it can increase the thickness of the lower esophageal sphincter muscles, Without fibrosis, it can be very helpful one, and it is always a new procedure, but it is effective procedure. That is how it is done. I am showing here with the statotherapy, one after another. It is used in the lower esophageal area, and ultimately the main aim is to make the lower esophageal sphincter more and more powerful, so that ultimately it prevents the reflux of the stomach contents to the esophagus. Then again, we have got the transoral incisionless fundoplication. This is another endoscopic fundoplication. It basically retracts the gastric cardia and make a valve-like effect on the lower esophageal sphincter. It reduces the number and the proximal extent of the reflux episodes, but it will take some more time for recommendation still in the early stage. Then we have the Medigas, where it is the endoscopically stapling system, it can be called. It can create an endoscopic partial fundoplication. Again, it needs some more studies for the final recommendation. We have got the anti-reflux mucosectomy. So this is the principle it is used, that when you use a mucosal resection, ultimately during the healing process of the mucosa, it can make some scar formation. And this results in the shrinkage and the remodeling of the gastric cardia, and it is helpful to enhance against the capacity and strength of the lower esophageal sphincter. And also it is helpful till today, what we are seeing. Here we have got the valve in the lower esophageal sphincter, but most of the patients with GERD, this valve is very much relaxed. If you do a mucosal resectomy, so after that, we can see here that after the resection, it can make the scar formation and it becomes very tight one in the lower esophageal sphincter. Again, it can be used probably for future. We have got the sphincter augmentation device. Here it is the mechanical augmentation of the lower esophageal sphincter. It is laparoscopically, it is implanted around the distal esophagus, and the magnetic attraction of these beads, actually basically it is the magnetic beads, small beads, and magnetic attraction of these small beads will be helpful one to control the lower esophageal sphincter, but it will not hamper to pass the food material to the stomach. You can see it from this picture. This is the magnetic beads put around the esophagus, but whenever the food comes from the upper part, due to more pressure, it will allow the food to go to the stomach. There will be no problem about it. Then we have the electrical stimulation therapy. So here again, it is a new method for endoscopic process. Probably for the future, it may be helpful. It is still in the nascent stage. Coming to the endoscopic and the surgical therapy of refractory GERD or Esophageal GERD, we have got the endotherapy, statotherapy or TIF. We have got the different surgical procedures. I'm not going in details about it, but it may be helpful from medical to endoscopic to surgery. So ultimately, what the staged approach we should follow. In the stage 1 is a lifestyle modifications, antacid, and sometimes you can use the H2 receptor antagonist. In the stage 2, always you can go for intensive therapy, PPI, single dose, double dose, H2 receptor antagonist, and sometimes even can use the prokinetic agent. And finally, in the stage 3, we have to go the extensive use of the PPIs, endoscopic therapy, and surgical therapy. That's how we should staged mannered approach should be applied. In conclusion, my friends, the GERD is a common problem with a worldwide prevalence. The lifestyle changes, medical and surgical interventions are ways in the treatment of the gastroesophageal reflux disease. The PPIs are more effective drug therapy today. The endoscopic procedure showed good results initially, but it will probably need for more data, more trials, and for final conclusion. With this, I thank all of you for your kind attention. Thank you.
Thank you, sir. It was a very well executed session. We have questions from our audience, sir.
Yeah.
So we'll go on to the first question.
Hmm.
What are the indications of anti-reflux surgery? And what is the efficacy? Is it helpful?
Yeah, I have shown a slide here. Basically, the slide clearly showed that there are some patients continuously, they have to be on PPI therapy for a long time. Sometimes once daily, sometimes even twice daily. Even then, they have got the symptoms. Those patients may sometimes require surgery, or they may prefer even themselves that I will go for surgery. Then again, if the patient cannot ultimately cope up with the medical therapy for a long time, they also need surgery. Then again, sometimes the patient has got the hiatus hernia. Then already I have mentioned that if the patient has got hiatus hernia, also he is having the acid pocket, probably they will again need the surgery. So these are 3-4 groups where we definitely need the surgery. The question is whether it is enough. That means surgery can give relief to the patient. It is not obviously in all cases. So some of the patients, even after surgery, they have to continue with the PPA therapy. So that's the problem with the post-surgery for reflux disease. So we have to ultimately adjust the life, and even after surgery, though it is needed, it is done. Probably you should be prepared to have some PPI or H receptor antagonist for relief of the symptoms.
Thank you, sir. We'll go on to our second question.
Yeah.
The question is, what is the role of endoscopy in the long-term management of patients with GERD? And under what circumstances should mucosal biopsy specimens be obtained?
Yeah, this is a very good question. The point is endoscopically, always we have to assess the patients, and already I have mentioned the different spectrum we have got. On one day, the mucosa will be completely normal on endoscopy, what we call the non-erosive reflux disease. There will be another group where it is the erosive esophagitis. So endoscopically, we can find out whether the patient has got any changes in the mucosa in the lower end or in the upper end even, and where they have got any ulcerations, complications, and one all. So that's why endoscopy at some point of time it is necessary. And the extreme end, we have got the Barrett's esophagus. It is directly related with the reflux disease. Once the chance of Barrett's esophagus we have found out, probably we should be very careful because ultimately it is a pre-cancerous condition. So we have to take care of this group of patients. So coming to the other question, the effectivity of the endoscopic therapy. First of all, I have shown different endoscopic therapy coming up, but it is still in the early stage. It is not established till today. All this endoscopic therapy may be very, very helpful one. It began long back. For example, stator therapy initially almost 15 years back it came, but ultimately it could not be a part of the usual treatment procedure of GERD therapy. But again, it is coming back. There is a revisiting of the stator therapy. Definitely, it is more modified today and it is helpful. But it is not the end of the answer. Then again, other therapies, again, I'm mentioning that it is the early part, probably will require some more time to come to a conclusion. Even the mucosal, what arms therapy and endoscopy mucosal resection, they have got their own plus minus. But probably we will need some more time to confirm how far it will be effective process for the treatment of gastroesophageal reflux disease.
Thank you, sir. Very well answered, sir. We'll go on to our next question.
Yeah.
What maintenance therapy is indicated for patients with typical esophageal reflux syndrome with or without esophagitis?
Yeah,
What is the usual maintenance therapy for patients?
yeah. This is very important point probably you have mentioned about the maintenance therapy. In fact, maintenance therapy of reflux disease itself is a big subject today. Because I have mentioned that PPI therapy, it is effective up to 90-95%. You can get relief of the symptoms, you can heal the ulcer. But the point is, once you stop it, within 6 months, the symptom recurs. All the ulcerations and esophagitis problem comes up again. So that's why we have to continue with the medication. Although today, I'm again and again saying that long-term complications or side effects of PPI is very negligible. So many questions were raised, but till today it is established that we should be careful, we should not misuse it, but it is till today safe. But having said that, those patients who have got the non-erosive reflux disease, most of the time they do not need to continue the medication for a long time. Initially, some symptomatic relief for 4 weeks, 8 weeks, or maximum for 3 months, 12 weeks. You continue the H receptor antagonist or PPI. After that, you can stop it. Or in the reflux disease itself, again, I have already mentioned that H receptor antagonist or PPI, you use it for maximum 12 weeks. After that, you have to go for maintenance therapy. So what is this maintenance therapy? Maintenance therapy means basically you use a medication so that his patient is becoming symptom-free for a long time. So what we can do, if the patient is NERD, non-erosive reflux disease, probably we can stop the medication and wait for the symptom to come. Or in case of reflux esophagitis again, we can stop the medication after 4 weeks or 8 weeks. You see the erosions or your inflammatory changes or the ulcerations are healed. After ensuring that, you can stop it. And on-demand therapy, I showed in the slide also, you can wait for or you can continue with on-demand therapy. Whenever the patient will be having the problem, symptoms, you use the PPI or H receptor antagonist for 2 weeks, 3 weeks, and after that again you stop it. Whenever the demand comes, you continue it 2 to 3 weeks and stop it. Then again, in some cases, even the patient has got the reflux esophagitis, the patient is symptomatic most of the time. In those cases, probably it means that you can continue some medication. Suppose initially you maintain it with the once daily PPI therapy, patient is symptom free, fine. After some time, after say 4 weeks or 8 weeks, you bring down from PPI to H receptor antagonist. The patient, you see how it is continued because H receptor antagonist, though it is less effective one, for maintenance it may be the better option because the concern about the PPI therapy may not be there. Then again, always in this group of patients where we have got the complicated GERD, complicated reflux disease, with the stricture, with the Barrett's esophagus, we have to continue the medication for a long, long time. How long? We don't have any answer. But you cannot bring down the medication PPI or we cannot come down to a H receptor antagonist in this group of patients with complicated GERD, what I mentioned, or the patient has got the Supra esophageal, the complication, respiratory problem. For a long time, you have to continue PPI, the minimum dose for long, long time as a maintenance therapy. And there is another way of the maintenance therapy of PPI or H receptor antagonist. is a weekly medication. So the 2 weeks, the weekends for 2 days or 3 days in a week, the patient will take the medication. After that, he will give a gap of 4 or 5 days without the PPI or H2 receptor antagonist. That is the weekend therapy, what we call as a maintenance therapy. But the message is always when the patient is symptom free, already you have used the medication for 4 weeks or 8 weeks or even 3 months, that means 12 weeks. After that, you try to reduce the dose of the PPIs. You bring down to your H2 receptor antagonist, or sometimes you stop the medication. That will be the ideal one as a maintenance therapy of uh, gastroesophageal reflux disease.
Thank you, sir. We'll go on to our next question. What is the best initial management for patients with suspected extraesophageal reflux syndrome? So
Yeah,
what is the
yeah. This is you're asking about the best medication what we have got. I
best
have already
initial
mentioned that.
management?
Yeah. Uh, so if the patient has got the extraesophageal manifestation, mainly, for example, the respiratory problems they have got, or sleep apnea they have got, all these issues, probably the best one will be you start with the PPI. Initially once daily, and if needs, you can go for even twice daily dose of PPI. So after 8 weeks, probably you can try to bring down two H2 receptor antagonists. Or sometimes H2 receptor antagonists may be added. Already I showed in the slide. The morning, suppose you are giving the patient with the PPI, at bedtime you can add a H2 receptor antagonist. That is also a good idea to control the symptoms of extraesophageal manifestation. Even for the asthma problem or respiratory problem, hoarseness problem, everywhere probably it is the best one. PPI, single dose, double dose, add on sometimes whenever necessary the physician will decide H2 receptor antagonist at bedtime.
Thank you, sir. We'll go on to the last question for the day.
Yeah.
What is the role and priority of diagnostic tests? The first one, endoscopy with or without biopsy. The next is esophageal mammometry, ambulatory pH monitoring, and impedance pH monitoring in the evaluation of patients with suspected esophageal GERD syndrome.
Esophageal
GERD syndrome.
syndrome. Okay. Uh, First of all, I have mentioned what are different modalities of the investigations of gastroesophageal reflux disease. The first thing we should remember that most of the places in the country we have got the easily available endoscope. We can do an endoscopy to assess the lower esophagus or as a whole the esophagus with endoscopy. Any changes in the mucosa, is it or not? Then we have got the narrowband imaging system. So even in white light, some minimal changes you cannot notice, but you can notice it with the narrowband imaging. Most of the cities nowadays we have got the narrowband imaging facilities as well. So initially probably we can stick to that. You can use the endoscopy as the preliminary investigations for gastroesophageal reflux disease. But coming to the other point about the manometry, for example, about the impedance, and all these procedures are not available in most of the places in the country, except few centers. So those are not required in all the cases as well. Only some small percentage of the patients, they will require the evaluation of the manometry, the pH metry, or the impedance facilities. We have to use it some cases, and basically these are the cases where the patient is not responding to your the treatment with PPI, what we call, I discussed about the refractory GERD. So these group of patients are very small numbers, And those patients, one by one, you have to go for the manometry, impedance, pH metry, and other investigation.
Thank you so much, sir. It was brilliantly answered to all the questions. The session was very informative and very well executed. We thank you so much for your time, and we learned a lot from you. Thank you. It is such a privilege to hear from you, sir. Thank you very much again. We look
Thank
forward to
you.
hear from you
Thank
again.
you, my friends also. We'll see again. Thank you.
Thank you, sir. Thank you, sir. We can now end the session, sir.